Okay, so our next speaker is Secher Jensen. He's a chiropractor and professor of the research unit for clinical biomechanics at SDU and Central Jutland Regional Hospital in Secher. His main research goal has been to increase the understanding of the clinical value of diagnostic imaging in people with back pain, with a clear focus on MRI scans. Through a systematic literature reviews and large cohort studies of people from both the general population and clinical populations. During his time at the Spine Central of Southern Denmark, he co-developed and managed the Spine Data Registry, one of the largest clinical registries in the world for patients with spinal pain. In recent years, his research focus has shifted more towards clinical guidelines, knowledge translation, and implementation to facilitate better multisectoral pathways for patients with back pain. He is also involved in the development and implementation of AI solutions for spinal MRI interpretation, including the identification of degenerative changes and severe pathology. So, welcome to.
Thank you.
The floor is yours.
Thank you very much, and thank you for the kind introduction, and thank you for the invitation to come and present here. It's a real honor for me. This is the hospital where I'm working. Just behind the letters here, you can see our lunch room. So we have a very nice view of Silkeborg city and the surroundings. So Silkeborg is quite a small town in Denmark, but we have one of the largest public spine centers in Denmark, the second largest. We have an uptake here in the central region of Denmark of 1.2 million people, and we see about 10,000 to 12,000 patients with spine pain each year. Research-wise, I'm affiliated with the University of Southern Denmark, which is in Odense, the birthplace of famous fairy tale author Hans Christian Andersen. And more recently, I've been appointed adjunct professor at University of Alberta in Edmonton. So that was a bit about me. But just going back to why I think the clinical value of imaging in low back pain is important is going back to my early student years and early research career years. I worked at a spine center, another one than that one I just presented, and I worked as an MRI technician at that spine center. And I developed, of course, an interest in how imaging works in these patients, and got curious that for some patients, MRI is the solution, and for a lot of patients, it doesn't make a difference at all. So why was that the case? So I did my PhD in clinical epidemiology in modic changes in the general population. And since then, as mentioned, I've moved into more also implementation research to see how the things that we learn from our research, how does that work in real life, and how do we implement those things that we learn and that works? How do we get our knowledge transferred to the clinicians? I think that is one of our key goals as researchers, of course, is to do research, but also to make it out in the real world and make it work. So the basic research that I do is mainly around MRI, trying to find out how MRI can be used best in low back pain and spinal pain conditions, try to see if there are techniques that are used in other anatomical areas, such as the heart or abdomen. Is that something that is useful for the spine as well? And then with the clinical cohorts, we try to fit the puzzles between research and the clinical everyday life. And then, of course, as I said, the last part and the important part is to get that knowledge out in real life. Yeah. So today I'm going to cover a bit about MRI and low back pain, of course. What do we know and what do we not know? What are the challenges and the knowledge gaps that, of course, bring us to the opportunities, where I'm going to talk about some of the less used MRI techniques for the spine and how to combine data to be more clear about the holy grail of what is low back pain. And I'll come back to that, hopefully. So clearly, this is my main area. That's what I know quite a lot about. The MRI techniques and stuff like the technical details. Please bleed gentle. I'm not that good with those. So, right, so low back pain. Is that an important condition in the world? Yes, it is. It's actually the leading cause of disability in the world. As you can see here from this WHO report, about 600 million people have low back pain each year, and it accounts to 70 million disability-adjusted life years. And that really always throws me away, that something as not very serious can also be that important in terms of people losing their ability to function as human beings just because of low back pain. So if you're interested in more about low back pain, I will advise you to read the Lancet Low Back Pain series from 2018, and then there's an update in 2023, which really covers the whole shebang about MRI or low back pain and how multifactorial it is and how difficult it is to try and tease out what low back pain is and what we can do about it. Because the main challenge with low back pain is that the main thing is that it's a pain experience. So it's a subjective feeling from each individual, how much we feel the pain, and especially what are the consequences of the pain that we experience. And as you can see here from the Lancet paper, there are different factors. Of course, you can have severe pathology, or you can have conditions such as osteoporosis that makes it more likely for you to get low back pain. There are some social factors. We know that people with low income and low education are more likely to get low back pain or experience low back pain. There are a lot of psychological factors that have been shown to be important in low back pain. It's anxiety, depression, fear of movement, and stuff like that. Of course, there are genetic factors that predispose to having or experience low back pain or being disabled by low back pain. Some of them are an increased inflammatory response. It can have to do with weak collagen fibers that make you more prone to injury. And then, of course, lastly, we have the biophysical factors. There are numerous of them, but of course, one of the best non-invasive ways to investigate some of these biophysical factors is MRI. It's a non-invasive procedure. Those of you who have seen MRIs, of course, you can see a lot of tissue, you can see the bone, you can see the muscles, ligaments, nerves, etc., all of which are potential pain generators in low back pain. And of course, you can sometimes see comorbidities. It can be fractures, it can be osteoporosis. Of course, sometimes MRI can also be used as a proxy for some of the genetic factors, where you can see, for example, in patients with spondyloarthritis, with who has a different inflammatory response as other people do. So, yeah. So it's fair to say that low back pain is a multifactorial condition, and that when we look at imaging, we're only looking at a small proportion of the whole puzzle. And just to complex things further, there are a lot of ways to phenotype patients with back pain. So this graph is from a paper by one of my good colleagues from SDU, who collected or looked at 10 studies that had looked at pain trajectories through time in about 9,000 patients in all who have been seen in primary care, for example, their GP or physiotherapist, where they come in with quite a high degree of low back pain, and then we follow them, for example, with text messages for a year to see how they go, and we can see that luckily the vast majority of patients with low back pain in primary care have either very mild pain or have a resolution of their pain quite quickly in their trajectories. And then we have two other groups of patients, each about a fifth of the population, that either have severe ongoing low back pain or have fluctuating low back pain. So that's just to say that we have all the factors, but we also have other ways of trying to phenotype patients based on their time, if it's acute or chronic, the trajectories that I just showed you, and also about the pain mechanisms. Is it mainly a nociceptive input? So do you, for example, if you have a spinal fracture, you have a large nociceptive input. And then you can have a neuropathic pain, which is more centralized, and the same as the nociplastic phenotype, where your central nervous system gets synthesized into thinking that even small inputs are painful. And then we can also phenotype patients by the way their symptoms are, if they just have local low back pain, if they have radiculopathy, that means pain in the leg, which is often seen for patients with disc herniations. And then we have neurogenic claudication, which is associated with central spinal stenosis. So, yeah. So it really is a big puzzle that we try to figure out how fits together. But let's look at how then MRI, how that fits into this large puzzle. And this is an illustration of the prevalence of MRIs, lumbar MRIs and lumbar radiograph that has been taken over the decades and how we have used it. And from the last 2.5 decades, we can see that MRI has increased quite rapidly. In Denmark, it's a 5-fold increase from 2000 to 2025, but with not the same reduction in radiographs. And it's a bit difficult to find out, how many MRIs are being performed in Europe each year, but my best estimate from Googling a bit is about 10 million lumbar MRIs only. So we can probably double that if we also add the cervical thoracic and the sacroiliac joints as well. And then just for the lumbar spine, that would be about 5 billion euros each year. And I'll come back to some of the challenges about using MRI that frequently. So when I try to find out or visualize what the role of MRI in low back pain is, I always look at it as any other paraclinical test that we have, for example, blood samples or whatever we use in the clinic. And those paraclinic tests, they should tell us either about the diagnosis. Does this patient have the diagnosis that we suspect they have? Can it tell us something about what treatment is best for this patient? And finally, can the test tell us anything about the prognosis of the patient? So let's see how MRI performs in those categories. And let's start with the diagnosis. So this is a lovely infographic showing you the number of, or the prevalence of degenerative findings in the skeleton in asymptomatic people, so people without pain. So if we focus on the disc or the spine, even young people like you, about a third or half of you will have disc degeneration in some form. When we get a bit older, like me, it's much larger. So when we reach the end of our life, almost everyone has disc degeneration and still not have pain. So, of course, when we are epidemiologists, we would like to see how does it look in a broader perspective. And what we do usually is to do systematic literature reviews. And these authors from America have done that a few years ago. We're now updating that in our research group. So far, we have screened 30,000 abstracts and titles, and are down to 500 full text at the moment. And hopefully, we'll get a bit lower than that. But here are the different MRI findings that are common in people both with low back pain and without low back pain. And what the group here did is that they had the number of studies. You can still see there are not that many studies out there looking at least 10 years ago. And what you can see is that some of these findings in asymptomatic people, people without pain, about a third, as I mentioned, have disc degeneration. But when we look at people with low back pain, the prevalence, of course, increases, or maybe not of course, but it does increase and gives us significant odds ratios for those MRI findings that I have highlighted. And these odds ratios are quite good in terms of low back pain research. They're not that grand. We can't, at a group level, say this person have low back pain and this have not. But at a group level, we can sort of say that this group of patients or people who have these type of changes in the spine are more likely to have low back pain. So these are for the individual findings. So looking at modic changes in people without back pain and those with back pain. But when I sit at my desk and look at all the MRIs, it is very rare for people to have just single MRI findings. What we usually see is that people have disc degeneration, as we can see here on the two lowest levels. They have disc herniations, annular fissures or high-intensity zones. They have some sort of bone marrow edema, modic changes, or as in this case, in relation to intervertebral disc herniations, that is small fractures in the end plate, which gives edema and probably pain. And on top of that, we have the muscles, and we have the facet joints, and we have the nerves as well. So conceptually, we did a study a few years ago where we tried to find out, is there a dose-response relationship between the number of MRI findings in the spine and the occurrence of low back pain? And lo and behold, that was the case. So compared to people without any findings, people who have 3 or more findings have an odds ratio of more than 14 to have low back pain. So that's just to indicate that, of course, it's good to look at individual findings, such as disc degeneration or modic changes, but I think it's important that we start to look at the whole spine as a unit. And one of my PhD students have a systematic review and review at the moment, where the overall conclusion of the 50 papers that are in that review is that there is this dose-response relationship, and that the number of findings or specific combinations of findings are more associated or stronger associated with low back pain than individual findings. It sort of makes sense. The more there is, the more wear and tear you have, the more likely you are to experience low back pain. Yeah. So let's move on to treatment. So are there any MRI findings that can tell us about or give us indication for specific treatments? So it would be very nice as a clinician, a doctor, a chiropractor, a physiotherapist who has an available MRI to say, well, you have this MRI finding, you need to have this type of treatment. And unfortunately, there are very few studies that have looked into this. We're talking about 10 studies when we look at these systematic reviews. And neither of these studies, or only one combination of MRI finding versus a treatment, is available for only single studies. So we don't have enough knowledge to say that this MRI finding needs this type of treatment for patients to be better. So that is absolutely a place to start investigating more, an opportunity for more research, so to say. And finally, if we look at the prognosis, things are looking a bit better. I was engaged in, or a co-author on this paper a few years ago, where we looked at if MRI findings can predict future low back pain. And at that time, we found that actually they couldn't, or there was very little research to indicate that it could or could not predict future low back pain. But luckily, there was an update of this just a few years ago, where there are much more studies included in the systematic reviews in those 7 or 8 years that were between the two reviews. So we can say a bit about how MRI findings predict low back pain. So in people with back pain, so if we take that group of patients where the most studies also are available, we can see that modic type 1 changes and type 1 and type 2 changes. This is where you have inflammation or at least edema in your bone marrow on the MRIs, and disc degeneration are predictors of poor outcome. So if you have these findings as a patient, you're more likely to have a poorer outcome than if you don't. If we look at asymptomatic people, then the amount of disc degeneration also predicts a worse outcome. And when we look at the general population or case control studies where we have both people with and without back pain, we can see it's also modic changes, both 1, 2, and 3, and disc herniations as well. Yeah, so I think that's about it for, oh yeah, no, just my thing about number of MRI findings. So again, in the same study I referred to earlier with where we look at the cross-sectional association between low back pain and MRI findings, where we found this dose-response relationship, we also looked at a smaller cohort of Mark Hancock's previous studies, where we also looked at who were pain-free after a year. What Mark did in this study was that patient came into a physiotherapy clinic with low back pain, then they had a treatment of low back pain, and when they were pain-free, they had an MRI. So everyone was pain-free at day 0 or at the beginning of the study, and then we did this survival analysis based on the number of findings in each of the patients at baseline. And then they were excluded, or it was noted when they had back pain again. And again, you can see here that people who had no or very few MRI findings at baseline, only 10% of those had a recurrence of their low back pain within a year, compared to 75% of people who had, again, 3 or more findings. So in terms of prognosis, there's also a dose-response relationship in terms of worse outcome. So the more findings you have, different levels, different types of findings, the more likely you are to have recurrence. Yeah. Good. So just to sum up about the role of MRI in low back pain before I get into the technicalities and the challenges and opportunities, we can fairly say that for diagnosis at a group level, we can sort of figure out who has low back pain and who doesn't, especially if we sum up or sum up the number of MRI findings. For the choice of treatment, that is probably where we have the least evidence. So please, if any of you have time for it, please, there's a big black dot on the atlas here where there's an opportunity. And in terms of prognosis, it's still not very good, but as I mentioned, for individual findings, it seems that there are individual MRI findings, modic changes, and disc herniation, or disc degeneration and disc herniations that can predict future low back pain. Yep. So, where should we go with the research in the future? Of course, as I mentioned, for the diagnosis, it looks like we're okay at a group level, but it would be very nice if we could, sort of individualize our diagnosis a bit better. And then, of course, for both the treatment and the prognosis, there are a lot of opportunities. And why did I put this in the back? Again? Yeah. So, as I mentioned, about 10 million MRI scans of the lumbar spine each year in Europe. Are they all necessary? And as I started by saying, they probably aren't. We can see from our department and from a systematic review that has been done, about a third of these MRIs are not necessary. We can do without them. The issue, of course, is to find out for whom is it appropriate and for whom is it inappropriate. And in our own department, we have, are you familiar with the Choosing Wisely campaign? No, okay. The Choosing Wisely campaign is a global campaign that tries to reduce unnecessary tests within the medical community. So that could be blood tests, it could be imaging, it can be treatments, stuff like that. And of course, we have looked at the MRI part for the lumbar spine, and we found out that about, as was in the review, that a third of the MRIs that we did in our own department were inappropriate. So when we get the referral from the clinicians, we look at, is this an appropriate patient to scan? And if we go back to that trajectory I showed, where there are this majority of people or patients that have reduction of their pain quite fast. So that group of patients do not need to have imaging. So if you go into your garden or whatever you do and you have acute low back pain, you don't need an MRI immediately. You should need at least 6 or 8 weeks before you can have an MRI. So we did that, and we have reduced the number of MRIs in our department, not 30%, but 20%, and we're tried to implement that in the whole of the region we're in the other radiology departments with not the same success, I can say. So again, this implementation thing, we know what is right, we can back it up with evidence, but when we try to implement it in clinical practice, there are barriers for that, but that's a whole other talk. So, going into the more technical details and where we can use MRI in a different way that we usually do to try and see if we can be more clear about the diagnosis, the choice of treatment, or the prognosis. I have 3 different techniques. One of them is upright MRI, another is MR elastography, and MR spectroscopy. Now let's start with upright MRI. So the idea about upright MRI, there are 3 different vendors, G-Scan, Paramet from Italy, and Phonar, I think also from Italy. So they all work on the principle that, at least for the spine and the lower extremities, if you're upright in a vertical position, you have the gravity that can make bulges, herniations in your spine be bigger. We know that when you put compression on the spine, at least degenerative discs will bulge more. So perhaps using upright MRI, where you have the gravity, can increase the diagnostic accuracy of the MRI. Because what has always, fascinated is probably the wrong word, but irritated me is that when we MRI patients with low back pain, we have them supine, lying on their back in the most comfortable position as possible, because then we get the best images. Because movement for MRI is very, very bad. Then we get bad pictures. But what is a diagnostic test worth if you don't do it provocatively? If you don't provoke the pain that the patient has, are you then not inclined not to have very high diagnostic accuracy? So that is the reason for doing the upright MRI, is to do the test in the position where the patient has their pain. For example, the radiculopathy when they have a disc herniation. So it would be easier to target, to find out more specifically where the problem is. And yes, we can. One of my PhD students just recently published a systematic review on upright MRI and found that it systematically shows the difference between the supine and the upright position. In this patient from our own hospital, I think, you can see there's a small disc herniation here in the supine and when they lie on their back, and when they get upright, you can see there's a larger disc herniation and high intensity zone, and that goes for some of the other. So that is so far so good. We can see more changes when we have people in the upright position. However, very few of these, I think there were 20 studies in this systematic review. Only 1 or 2 asked the patient if their system changed from lying down to standing up. So we don't get any clearer on the clinical significance of using MRI, upright MRI. So we still need to do more and better research in upright MRI. If you have one in the area, please go ahead. But please bear in mind that we do have issues with image quality, mainly due to the low field of the MRIs. The upright MRIs here, this is a 0.25, this is 0.5, and this is 0.5 Tesla, where normal MRIs are 1.5 or 3 Tesla. The other issue is that when you're upright, it's really hard to stand still. So there will be a lot of movement, which will reduce the image quality. And for this system, which actually performs best, I would say, from the 2 others, you can see the gantry it's 40 centimeters. So people above average weight don't fit into it. And that's a bit of a problem now that we have more bigger patients. Another issue here is with all of them is that when you do an upright MRI in a low Tesla scanner, you have to prolong the examination time. And I don't know if you have tried to stand up for 20 minutes without moving your legs, you get low blood pressure. And one of my colleagues who did his PhD on one of these actually had people fainting when they were in this position. So there's quite a long drop and potential head injuries if you fall from this position. So he had to develop cuffs that can sort of mimic the venous return of the venous blood to the heart. So basically, it's a very good idea. It needs better refinement in order to work better. Great. Moving on to elastography. Elastography is a technique where you use waves to, in terms of MR elastography, you use, it's probably better shown here. Yeah. So we have a big subwoofer that can control the air pressure that then goes into these actuators, which are, just like a massage apparatus that can send waves into the body. And the waves then deform the tissue, and with the right phase contrast sequences with the MRI, we can quantify that. Usually, or in the beginning, it was used for liver, for fatty livers, and in this study, for staging tumors in the liver. And some studies have shown that for different tumors, both in the abdomen, in the organs, and in the brain, the elastography or the elastogram can predict the prognosis of the patients. But in low back pain or in the spine, what we do is that we can, of course, quantify the stiffness of different tissues. We use a normal T2 weighted image in order to get the anatomy, and then we can copy regions of interests from the T2 image to the elastogram and then quantify the stiffness of the tissues. And if you can see this, these are fish oil capsules, so they're not important. But what you can see here is a disc where you have quite another signal or another stiffness within the nucleus as related to the surrounding annulus. And you can see there are differences in the different types of the psoas muscles and the paraspinal muscles. So yeah, so this is just an illustration of the waves going through the disc, and then again, the different stiffnesses within the disc. This is from some of our collaborators at Ohio State University. But again, we did a systematic review of this and found that it is quite promising, and it can quantify both the stiffness in the disc and in the paravertebral muscles. And in terms of the disc, the stiffness correlates with the Fearman grade, the grading of disc degeneration. And it shows that for the muscles, we can see that there are different muscle stiffness before and after exercise, and in different conditions. For example, what do you call it? Paralysis. You can see that there are differences pre and post treatment. Yep. The final thing I would like to cover here is, or second last thing I would like to cover is MR spectroscopy, which is a totally different way of using the MRI. So basically, MRI, the signal that we get from an MRI scan is from the protons in the body, and how movable they are in different tissues. What spectroscopy does is to quantify other types of molecules, and we can see from different studies that what you can see in degenerated disc is a shift in some of these peaks from proteoglycans, lactate, and lipids, and water, of course. And we're also, at the moment, writing up a review of that. There are very few studies of it, but on a single study basis, what so far has been done that is clinically relevant is that a group from Jeffrey Lutz in the US, their group has quantified the profiles, the spectroscopy profiles for each of these discs, and then correlated with a provocative discogram. A provocative discogram is where you take a fairly sizable needle and inject the disc into a person or a patient, and then ask if they get pain when you inflate the disc with saline. So in these studies that this group have done, they have found a correlation between different profiles. So you can see these peaks of lactate and phosphate, I think it is, something else. You can see that the profiles for a non-painful disc is different from a painful disc. And at the moment, they're trying this out in an RCT in Norway, in the surgical department, to see if it has predictive value for the treatment. And the same group has looked at propionic acid. As those of you who are familiar with modic changes, one of the etiology ideas is that is based on infection with propionic, with acne bacteria, which produce propionic acid. And what this group has done so far in quite a lot of patients is that they have quantified that patients with modic type 1 changes in general have more propionic acids within the disc adjacent to modic changes. But that there still are a number of patients with modic changes that do not have propionic acid. So there are probably some patients who have infections or have modic changes due to their infection, and of course someone that don't. But this would be a very nice way to see if patients who have propionic acid within their discs are more likely to get better from antibiotic treatment, which is still a controversy in this area. So then we have machine learning for lumbar MRI, and why is that important? Well, I can speak for myself and my radiological colleagues that there is general, at least in Denmark and a lot of other countries, a lack of radiologists. That increases the workload, and it takes up capacity when we have lumbar MRIs. I said we do a lot. And we have people who have much more severe conditions that we would like to scan instead. So if we can have AI or machine learning to do our job, that would be great. I could do more research then. There are a number of groups that work with this. There is SpineNet at Oxford University, Deep Spine in Munich, Colombo in Italy, and Secher Medical in Denmark. There are probably more, of course. But the idea is to enhance the diagnosis, reduce the interpretation time and the variability. Unfortunately, variability is quite an issue in spinal MRI. If you're familiar with kappa values, reproducibility of identifying and quantifying different MRI findings, it's not that great. It's 0.7, and for some even lower. So if we can use lumbar MRI or AI, we can hopefully decrease the variability, of course, based on the available data for the AI tool that we have. Hopefully we can improve patient care, or at least divert some of the scans that we do now to some patients who have better need for it, and improve our research opportunities. Machine learning can also be used in other ways. These are from the Deep Spine group in Munich, where there is a large cohort of the general population in Germany with 24,000 people being MRI scanned, blood, questionnaires, etc. But of course, when you scan that many people, you have to reduce the number of sequences that you use for such a large project. So what this group have done is that we have only a T2 weighted and a T1 weighted Dixon sequence. And from that, this group have been able to do a stir image, from these images, used machine learning to produce an artificial stir image, which is one of the sequences that we use when trying to identify inflammation and edema. Another one from the same group is to make quite detailed segmentation of the spine from the MRI scans. I think these are available online somewhere, GitHub or something like that. So, trying to move this into real life. I'm on a project at the University of Alberta, along with these partners, so Alberta and Canada is quite big. It's the size of Portugal and Spain together, but with only 5 million people. And as you can see, they are mainly here around Edmonton, which is the capital, and Calgary in the south. But there are, of course, people living in the rural areas as well. And one of the big challenges that the healthcare system in Alberta has is that when something very serious happens to these people, there's a long way to transport them to specialist care in Edmonton, for example. So this project uses AI for stroke and low back pain to try and triage patients better at the local emergency departments, and trying to help the clinicians triage their patients in order to which one gets to the patients who needs to get transferred to specialist care. The main thing that we're working on is stroke, which is, as you know, it can kill you, but it is also curable if you get the proper treatment within time. So what we do with the Secher Medical Neuro Suite is that is available in terms of just radiologists looking at it, at the images. And then based on that, of course, we can try and triage the patients who need to go to Edmonton for specialist care, and hopefully reduce the number of unnecessary transports, and then reducing the overall costs of the health care for these patients. And then piggyback riding on that, we have the same going for the lumbar spine. Final thing I will cover is combining data. Because as I started by saying, this is a multifactorial condition, and with lots of different phenotypes, and can be quite hard to sort of rule out what one factor, for example, MRI, how that affects low back pain. So luckily, we have Denmark, which is kind of a registry heaven. So every Dane has a central a CPR number, a central person registry number that follows, that you have from your birth and all the way till you die. And every time you get in contact with the healthcare system, educational system, your work life, anything is recorded within registries in Denmark. So we have data on all our 6 million people in Denmark. Some of these registries, the cancer registry, goes back to the 1960s. So in terms of low back pain, we now have access to a whole lot of things that we didn't have before. We have the MRIs, which we now can quantify using one of the AI tools. In one of the projects I'm involved with, we use the SpineNet from Oxford. We have data on these PROMs, are patient-reported outcome measures. That is something we have at the spine center that I worked with previously, where we have the project that we're working on now, and we have only had funding for 1,200 patients out of 50,000, but we're hoping to get money for the rest, is to use these registries that we have in Denmark for all these things, except genes and omics. But all the other things we can try to fit into a model and hopefully be better at finding out how much does the things that we see on MRI, how much does that explain the low back pain. We are also trying to get EU money to include genes and omics into this model. And what we use for that is the Spine Data SDU database, which is a database that has access to all people in Denmark from all our registries, and we can then have what do you call it? We have access to all things that are related to low back pain. So we can, at the moment I'm doing a project where we look at all patients or all people in Denmark from the last 2 decades who have had MRIs or radiographs for their low back pain. And we follow them over 20 years. So I think that is the main thing. I know it's quite a long way from what the previous presenter had about cells. So this is quite the opposite, a broader perspective. So just to wrap up, as I mentioned, MRI can be used at a group level to look at the diagnosis. It's a bit harder to try and use MRI as a treatment to tell the patient what kind of treatment they need, but it can tell a bit about prognosis. I think the opportunities within MR research in spine pain is to focus more on more findings over single findings, if we want to crack the nut of low back pain, and then try to explore unconventional MRI techniques, some of them which I have showed you. One thing that didn't get into this is real-time MRI, where you can sort of see movement within when people move in real time. And of course, as I mentioned last, is to combine data. Yep, I think that concludes it.
Okay, so thank you for this nice talk. So now time for questions.
Well, I just wanted to ask, could you tell a bit more about how you are planning to combine the data in your last,
In our next study, or?
Yeah, what are the ways to combine, like how you are planning to do this?
Okay, so at the Spine Center, we have this registry that I helped build some years ago, where we have clinical data. So we have questionnaires on every patient that comes to the clinic, and we also ask them for follow-up questions, but they don't respond, so we don't use that. So we only use the things that are in the clinic, and we also ask the clinicians, when they have done their examination, to put that into the registry. So at the moment, we have these 50,000 people or patients where we have MRI as well. So we will have SpineNet coding the 50,000 MRIs, because we can't have radiologists do that, or myself. And then that data will, at an individual patient level, go into that spine data registry that I showed you, where we have all the public registries. And we can then link each patient to the registries where we know what level of education they have, what income they have, how many kids do they have, what other diagnosis do they have, what type of medication do they use, do they have any comorbidities, all that. And then what we will try to look at is how the MRI profile, so what I said about the single versus the many MRI findings, how does that affect the trajectory of the patients? So when after they have been to the spine center, can we see, for example, what I expect we would see is that people who have a lot of MRI findings will have a lot of healthcare utilization after their visit, because it would be magical if the spine center could cure them just by one visit. Of course, they would get pain sometimes after that. So that is one thing we would look at. Another is we're texting these 1,200 people or patients that we have funding for. We will send them text messages every week to see, have they been off work, how much pain do they have, and then we will try to see if the MRI findings or combination of MRI findings, how would that predict these trajectories I showed, the one with the good curve and the one with the fluctuating and the one with the severe pain. So.
Okay, thank you.
You're welcome.
Do you think it would be possible, like in the future, that you can classify patients just by their characteristics from a database? So if you have a new patient, could you just say, okay, I find similar cases in my database or something?
That's the idea about the sort of the EU grant that we're proposing, is that we hopefully, from when we have the proteomics included with all the other stuff, that we can sort of build a flowchart, in a better word. Yeah.
Thank you very much for your nice presentation. It was actually really interesting. I have a question about, at the beginning you showed 3 different outcomes, right?
Yep.
One is that they kind of declined, 60% luckily. They don't need MRI, this is what you said. Not necessarily, I mean.
Not necessarily, no.
Then we have one which has really persisting problems, and then we have one which is oscillating, right?
Yes.
Do you have specifically data for the oscillating groups on mRNA to know why is it oscillating? Do they have different reasons for this, or did you investigate this group?
That is what we want to investigate in this new project, where we have funding for about 1,200 patients, where we can then see the trajectories, and then hopefully we can predict which are they severe, fluctuating, or mild from the MRI scan, when we fit it all in with all the other symptoms and psychosocial profiles and stuff like that.
Okay, and one short follow-up question about this database that you said who has access to it? Is it something that people from outside could access also, or is it something really just local?
No. Actually, it is open for access from outside. There is a steering committee. So if you Google Spine Data SDU, there is, I know it's quite new, so they're setting up the website, so maybe it doesn't work perfectly well. But there should be an email where you can, and a form where you can apply for access to data. It usually comes with a clause that for example, if you wanted to do stuff about MRIs, I would probably be asked, does your idea fit with something that we are already doing? Then we will have a talk about, is this idea that you have, is that novel enough to get own access, or should we do some collaborative stuff in that instead? So.
Okay, thank you very much.
You're welcome.
Sorry, could you also maybe just shortly explain what kind of data would be available in this spine data? Like what is like, just like a rough...
There is a variables list on the website. But basically, as I said, every contact with healthcare, both in primary and secondary care, for all hospital visits, we have a diagnosis. It's linked to the cancer registry, education, income, other social stuff that I can't remember just on the top of my head. But it's quite big. So if you're on sick leave or stuff like that, it's also there. So.
Okay, so which are like the basic requirements to like diagnose biophysically that you have low back pain, or it's just like only having the pain, it's enough? It's enough.
You ask the patient, do you have pain? And if they
no,
say,
but do you need like a, I don't know, like deformation in the bone or something like that, or in the tissue to diagnose low back pain, or it's just with the pain, it's enough?
well, generally speaking, people also had low back pain before we had any techniques that could show that where their pain potentially comes from. So, as I mentioned, MRI can be used at a group level, but very rarely at a personal level. Okay. So if we MRI scanned you or me, I couldn't point to where you had back pain. Okay. That would be quite impossible. I can say that most likely it's this or that.
So maybe just before, you had a question? Yeah, so just to follow up on that before the next question, shortly, that's a bit the holy grail. I mean, so you want to see on the image, so pain has many dimensions. So there was a slide with nociceptive pain, so linked with inflammation, neuropathic, links directly with nerve injury, and then you have the tricky part of pain, which is nociplastic, when you've been subjected to pain during a long time. So you don't need the inflammatory signals for your nervous system to send already pain signals to your brain. And if you can rationalize basically the notion of pain by looking at MRI evidences, so you know a bit better how to cope with pain. So if you have a patient, for example, with strong nociplastic pain, and you decide to make an invasive surgery on this patient, you might not be taking the right decision, because the surgery will probably not be able to treat the pain because it's nociplastic. So if you have the right biomarkers, I mean, you can correct me if I'm totally wrong, but if you have the right biomarkers, basically you have a chance to better diagnose the pain and then to have a bit more precision treatment.
Yeah.
Is that so?
That's correct.
Yeah.
Very beautifully put.
Hi.
Hi.
I have two questions. One of them is, you said that, well, I understood that there are patients that the MRI is completely unuseful for them, yeah, because you cannot diagnose anything based on what you view. Yep. And I was wondering if you might have thought that back pain might be related to other things, like other conditions, like maybe the stomach or other organs in the body, yeah, that have the nerves that go to that, yes, lower part of the back, and that creates the pain. Is that
we do? Referred pain is what we call it when you have, for example, if you have pancreatitis, then you have often pain in the thoracolumbar spine, but so we won't see that on the MRI. But the patient still has pain, but it's just not from the spine. So
you treat it with diet or?
Actually, in our clinic, we would probably hopefully in a situation where it comes from an organ and not from the spine, the clinician usually picks it up. So the doctor that you see will hopefully palpate your stomach and find out, it's the pancreas that creates the back pain. So I won't refer to an MRI. I would refer to a CT scan of the abdomen instead.
And then when you were talking about that initiative that is about reducing the amount of tests that people are taking, like blood work and everything, I was wondering, how do you know that someone, like up until you have done an MRI, you don't know if that person maybe has something serious, no? And how do you plan to reduce?
Yeah, good point. We know from, well, first of all, when you have back pain, serious pathology is very rare. It's 1 in 100 that will have cancer, and that is why they have back pain. And when you have cancer, and have back pain, you usually have other symptoms as well. You have weight loss, you have pain in the night, you have perhaps fever in the night, other symptoms that will make your doctor aware that this is not just a disc herniation, this is something serious. And then again, they won't refer to an MRI, they will refer to a CT scan and blood works and all that. So, and that is why the guidelines at the moment is that unless there are signs of serious pathology, including cancer, you shouldn't have an MRI of the lumbar spine until after you have had a treatment with conservative management, so physiotherapy, medication, chiropractor, exercises, stuff like that. And then if it doesn't go away or it gets worse within 6 or 8 weeks, of course you can then be referred to an MRI after that. So it's to let nature work its magic and try to filter out that curve of patients who get better by themselves. So I hope that.
Thank you.
You're welcome.
Okay, last question.
Hi, I was, earlier in your presentation you talked about relating the number of MRI findings to the likelihood of a patient having low back pain, for example. And on my own observations in the literature, there's not necessarily consensus on how people quantify or grade disc degeneration, for example.
True.
But what I've noticed is that they often rely on qualitative metrics to assess disc degeneration. And so I'm curious if clinicians, radiologists, if they, in current clinical practices, usually just rely on qualitative measurements, or if they also rely on other metrics. And if that's true, if that's the case, and it lines up with what I'm seeing in literature, if that's a reason for lack of research into quantitative metrics, or if it's a case of maybe it's a larger financial burden to be able to capture that data.
Those are both great questions. So the first is, yes, we only use qualitative assessments in the clinic. So we use, for example, for disc degeneration, Fearman's classification, normal, mild, moderate, and severe disc degeneration. So, of course, as I said, there is quite a variability in how radiologists grade a disc between them, and for my own example, how I grade a disc today versus in a week. So there is the variability. And yes, to answer to the second question, yes, there is research going on at the moment and has been for quite a number of years, to quantify these different disc findings, and disc degeneration being one of them. And most particularly what we're interested in is how to normalize disc degeneration versus biological age. So we know that some people get disc degeneration early in life, and that's abnormal. But as I mentioned, disc degeneration late in life is normal. So we would like to be able to age and sex normalize an MRI scan which would then perhaps make it easier for us to pin out what are the clinical applications of it. So.
Okay, we should move on. So let's
Yep.
thank again speakers.
And thank you for your questions.